It really is kind of staggering when you think about it.
Hmm.
Before the MMR vaccine, rubella was just, well, everywhere in the UK. Hundreds, sometimes thousands of cases a year.
Hmm.
And the awful part was the effect on unborn babies. It really makes you appreciate, how far we've actually come.
It really does. So yes, today's deep dive is all about rubella, or as many people know it, German measles.
Right. And if you're listening because you need to get a really solid handle on rubella, maybe for revision or just to get up to speed quickly, this is definitely for you.
Exactly. We're aiming to cover everything from the absolute basics right through to the potential complications. Think of it as a quick but really thorough guide. We want to make it manageable, memorable.
Yeah, cut through the noise.
Mm-hmm.
And we're basing this on some really comprehensive revision notes, which is great, so we know we're hitting the key stuff, giving you that balanced view.
Absolutely.
So the mission, if you like, is to pull out all the crucial need-to-know info on rubella, just for you. Okay, so let's start right at the beginning. What is rubella exactly?
Okay, so fundamentally, rubella is a viral infection. It's caused by the rubella virus. Now, often it's quite a mild illness in, say, children or adults.
Okay.
But the real significance, the reason we talk about it so much, is the serious harm it can cause if a pregnant woman catches it, especially early on. That can lead to something called Congenital Rubella Syndrome, or CRS.
CRS, right.
And it's also worth remembering, it's a notifiable disease here in the UK.
Ah, notifiable. Good
That's
point. So
the-
doctors have to report it.
Precisely. Public health authorities need to know about confirmed cases.
Now that name, German measles, it makes it sound like it's linked to regular measles. Is that right?
Yeah, that's a really common thought. And it does have a bit of a history.
Mm-hmm.
The name kind of stuck from way back when it was first being distinguished.
Mm-hmm.
People thought it might be a milder form of measles, maybe described well by German physicians initially, hence the name. But actually, we now know it's caused by a totally different virus.
Completely different.
Yeah.
So while the name might, help you remember it's one of those rash illnesses, it's definitely not a type of measles. It's its own thing.
Okay, that clears that up nicely. So what is the actual virus then? What's the etiology?
The culprit is the rubella virus itself. It's an RNA virus from the genus Rubivirus and the family Togaviridae.
Right.
What's quite interesting, especially from a public health angle, is that humans are the only known host.
Only humans.
Yep. And there's only one main antigenic type. That's actually a big plus when it comes to vaccines because you don't have loads of different strains to worry about. Makes developing an effective vaccine, like MMR, much more straightforward.
Ah, that makes sense. One target. So how does it actually get from person to person? How does it spread?
So the main route is through respiratory droplets. When someone who's infected coughs or sneezes, they release tiny droplets containing the virus into the air.
And then people nearby, in close contact, can breathe those droplets in. And crucially, as we mentioned, a pregnant woman who gets infected can pass that virus across the placenta to her developing baby.
Right, vertical transmission.
Exactly. And it's important to stress it's person to person via these droplets. It's not spread by insects or anything like that.
Got it. Airborne droplets, close contact. So thinking about risk factors, who is most likely to actually get rubella?
Well, the main group, unsurprisingly, is anyone who hasn't been vaccinated or hasn't had rubella before. They just don't have the immunity.
Makes sense. No protection.
Yeah. And obviously, being in close contact with someone who is infected increases your risk. And then the really high-risk situation we keep coming back to is pregnancy in someone who isn't immune to rubella. That poses a risk not just to the mother, but much more significantly to the baby.
Okay, so it really boils down to immunity and exposure.
Yeah.
Right. Let's dig into how the virus actually operates inside the body. What's the pathophysiology?
So first off, the virus gets into the respiratory tract, your nose, your throat, and it starts replicating there.
Okay.
From there, it doesn't just stay put. It spreads through the bloodstream and invades various tissues in the body.
Right.
Now, the really critical part in pregnancy is when that virus manages to cross the placental barrier and infect the fetus.
And that's where the damage happens.
Exactly. What's quite specific and concerning is how it can interfere with the development of the baby's organs. It seems to particularly target the heart, the eyes, the nervous system, and the skeletal system.
Wow.
Which explains why you see those specific problems like deafness, cataracts, heart defects in congenital rubella syndrome.
That paints a very clear and quite worrying picture.
Yeah.
What about the timing? From exposure to symptoms, what are we looking at?
The incubation period, so the time between getting infected and symptoms starting, is actually quite long for rubella, usually somewhere between 14 and 21 days, 2 to 3 weeks.
2 to 3 weeks, okay. That's quite a delay.
It is, and the infectious period is also important. Someone with rubella can actually spread the virus for about a week before the rash even appears.
A whole week before.
Yep. And then for about 4 days after the rash starts, they're actually most contagious just before and right when the symptoms kick in.
Right, when they start feeling unwell.
Exactly. And just to hammer it home, spread is via those airborne droplets between close contacts. Definitely not arthropod-borne, no mosquitoes involved here.
Okay, good to be clear. So
Yeah.
that longer incubation is definitely something to keep in mind.
Yeah.
You mentioned a mnemonic earlier for the progression.
Yes, just a simple one. Respirate tissue fetus harm helps remember the path. Respiratory tract, then tissue invasion, and potentially fetal harm in pregnancy.
Respirate tissue fetus harm.
Mm.
Got it. Okay, now let's talk about how common this actually is or was. What's the epidemiology look like?
Well, historically, before the vaccine, rubella was incredibly common in the UK. It was mostly seen in kids, particularly the 5 to 9-year-old age group. In fact, it's thought that before widespread vaccination, pretty much most adults had actually had rubella during their childhood. It was just a standard childhood illness.
Wow, almost everyone. So the vaccine must have made a massive difference.
Oh, absolutely dramatic. The MMR vaccine introduction just caused this huge plummet in cases. I mean, if you look at the figures for England and Wales between, say, 2015 and 2017, we were seeing maybe just a handful of confirmed cases each year.
Single figures.
Literally single figures some years. It's an incredible testament to how effective widespread vaccination is. You get that herd immunity protecting everyone.
That's amazing progress for the UK. How does that compare globally?
It's definitely more varied around the world. The WHO still estimates something like 100,000 cases of congenital rubella syndrome happening globally each year.
100,000, wow.
Yeah. So while it's rare here now because of high vaccination rates, we do still see occasional outbreaks, usually in communities where vaccine uptake might be lower for whatever reason.
Right, pockets of vulnerability.
Exactly. And it's also true that most of the infections we see in pregnant women here now tend to be in women who are unvaccinated, or perhaps women who caught the infection while traveling abroad.
Okay, so vigilance is still needed, even here. Now let's move on to spotting it. How would you actually recognize rubella? What are the clinical features?
Well, the symptoms are often quite mild, which can actually make it a bit tricky sometimes.
Okay.
Typically, you'll get a mild fever, and a really characteristic sign is generalized lymphadenopathy, swollen glands.
Where specifically?
Pay attention to the neck glands, cervical, those under the back of the skull, suboccipital, and particularly behind the ears, postauricular. Those posterior auricular ones are quite classic.
Behind the ears, okay.
And then, of course, there's the rash. It's a maculopapular rash.
Maculopapular, can you break that down again?
Sure, so menicocles are flat spots, papules are slightly raised bumps, both usually pinkish or red. In rubella, this rash typically starts on the face, often behind the ears first, and then it spreads downwards, quite quickly usually, covering the trunk, arms, and legs.
Spreads downwards from the face.
Okay.
Any other symptoms?
Yeah, adults, maybe more often than kids, can get joint pain, arthralgia, and sometimes there's a sort of lead-up phase, a prodrome, especially in adults.
What does that involve?
Just feeling a bit off, lassitude, maybe a low fever, headache, perhaps mild conjunctivitis, bit of red eye, and maybe loss of appetite. This might happen a day or two before the rash.
Okay. And the rash itself appears when, typically?
Usually around 14 to 17 days after they were first exposed to the virus.
Really?
And sometimes you might see little red spots on the soft palate, the roof of the mouth at the back are called Forsheimer spots.
Yeah.
But they aren't specific to rubella. You can see them in other things too.
Forsheimer spots. Okay, not diagnostic on their own then.
Yep.
So let's try an example question then. Say a child comes in, mild fever, glands up behind the ears, and a rash that started on the face and is now moving down their body. What are you thinking?
Well, rubella would definitely be high on your list of possibilities with that classic picture.
Definitely. And there was another mnemonic for the features.
Yes, fetal RGMLAP. So fever, lassitude, rash, then glands, maculopapular rash, and lymphadenopathy again, just to really stress those swollen glands.
Filar RGMLAP. Great. Now, because it can look like other things, what else needs to be on the differential diagnosis list?
Yeah, this is important because lots of things cause fever and a rash. You've got to think about other common viral infections first.
Like measles.
Definitely measles, though the pattern is often different. Also, parvovirus B19, that slap cheek disease, herpes virus 6, which causes roseola infantum, various enteroviruses, adenoviruses.
Okay, quite a few viruses.
Yep. Also things like CMV, maybe even acute HIV infection, hepatitis viruses, echovirus, Coxsackie virus.
Yeah.
It's a long list.
Anything non-viral.
Absolutely. Bacterial infections like scarlet fever, others like brucellosis, Kawasaki disease, even secondary syphilis or toxoplasmosis could present with rashes sometimes.
Okay.
And if there's a travel history, you have to consider tropical viruses too, things like dengue, chikungunya, Zika, West Nile.
Right, depending on where they've been.
Exactly. And crucially, don't forget non-infectious causes. Drug reactions are a big one.
Ah, good point.
Like the rash you can get with amoxicillin if someone actually has glandular fever, or reactions to things like anti-epileptic drugs. So yeah, just looking at the patient isn't always enough to be sure.
That's a really wide differential.
Mm.
So how do you actually confirm it is rubella? What investigations do you do?
Well, you start with the clinical picture, obviously the symptoms, the history, any known contact with the case.
Mm-hmm.
But to be certain, you generally need lab tests. The gold standard is serology, a blood test looking for rubella-specific antibodies, specifically IgM and IgG. Your local health protection unit usually provides the kits and advice for this.
Serology. Okay. Anything else?
You can also use PCR polymerase chain reaction. That test actually looks for the virus's genetic material. It can be done on throat swabs, urine, or blood, especially early on.
PCR for the virus itself.
Yeah, and sometimes a full blood count might show some general pointers, like a low white cell count with more lymphocytes than usual, or maybe a temporary drop in platelets thrombocytopenia, but those aren't specific to rubella.
Right. Suggestive, but not definitive. So blood tests, serology mainly, are key for confirmation.
Okay, so let's say it is confirmed. How do you manage rubella? Is there a specific treatment?
Unfortunately, no. There isn't a specific antiviral drug that works against the rubella virus. So management is really all about supportive care.
Meaning?
Just helping the person feel more comfortable while their body fights off the infection. So rest, plenty of fluids, that sort of thing.
Okay.
And really importantly, isolation. To stop it spreading, people with rubella should stay away from school or work and avoid contact with potentially susceptible people, especially pregnant women, for at least 5 days after the rash first appears. 5 days from rash onset. Got it. What about for fever or pain?
Simple analgesics like paracetamol are fine for fever or aches and pains. But it's really crucial to avoid aspirin in children under 16 because of the risk of Ray's syndrome.
Right, no aspirin for kids. And what about the pregnancy situation? If exposure or infection is suspected in a pregnant woman?
That's treated as an urgent situation. You need to ask carefully about any contact, investigate any suspicious illness immediately. Confirmation often involves discussion with a virologist.
Right.
And management absolutely needs specialist referral and expert input because the risks to the fetus are so significant you can't manage that casually.
Yeah, the stakes are just too high. Okay, so generally, what's the outlook? What's the prognosis for someone who gets rubella?
Well, for most people, children, non-pregnant adults, the prognosis is excellent. They usually make a full recovery within a week or two. No lasting problems.
That's good.
But as we've stressed, for a baby infected during pregnancy, the prognosis can be very poor, with lifelong disabilities resulting from congenital rubella syndrome.
A real contrast there. So prevention is obviously paramount. How do we prevent it?
Prevention is key. Isolating cases helps limit spread, obviously. But the absolute cornerstone is vaccination with the MMR vaccine.
MMR.
Yep. Measles, mumps, rubella. In the UK, it's given routinely to children in their second year with a booster dose before they start school.
Right.
Antenatal screening is also really important. It checks pregnant women for rubella immunity. If a woman is found not to be immune, she can't have the MMR during pregnancy because it's a live vaccine.
Okay.
But she should be offered it soon after delivery. That protects her for any future pregnancies.
Protects the next baby. Makes sense.
And we need to keep reinforcing that the MMR vaccine is safe, it works really well, it's highly immunogenic and effective, and it's been the main reason we've seen such incredible progress in controlling rubella, even moving towards elimination in regions like Europe, thanks to vaccination and good surveillance.
Vaccination really is the hero of this story. Now, we've mentioned the complications, but maybe let's just list the main ones clearly again.
Definitely. The biggest, most serious one is congenital rubella syndrome, CRS.
Right.
That results from maternal infection, especially in early pregnancy, causing severe birth defects. Deafness is very common, cataracts, heart problems, intellectual disabilities. It's still a major issue in parts of the world with lower vaccination rates.
Truly devastating.
Yeah.
Are there other, maybe rarer complications from getting rubella itself?
Yes, though thankfully much less common. You can occasionally get encephalitis, inflammation of the brain, usually starts about 6 days after the rash, but most people recover fully from that.
Okay.
Arthritis or joint pain, arthralgia, is actually quite common, especially in adult women. It's usually temporary.
Mm-hmm.
Thrombocytopenia, that low platelet count happens in about 1 in 3,000 cases.
Mm.
And then there are very rare complications like Guillain-Barré syndrome, other forms of neuritis, or an extremely rare late-onset brain disease called progressive rubella panencephalitis.
Okay, so mostly rare, apart from the joint issues in adults, but CRS is the big one to prevent. Right, let's try and summarize. What are the absolute key takeaways for our listeners from this deep dive on rubella?
Okay, main points. Rubella is contagious, caused by a virus. The MMR vaccine is incredibly effective and the key to prevention. For most people, it's a mild illness.
What?
But the huge danger is infection during pregnancy, especially early on, which can lead to severe and permanent birth defects, congenital rubella syndrome. So maintaining high vaccination rates isn't just important, it's absolutely vital to protect pregnant women and prevent CRS.
Absolutely vital. It really hammers home the ongoing importance of vaccination programs, doesn't it? Not just here, but globally. It's about community protection.
Exactly.
Okay, brilliant. Well, for listeners wanting to cement this knowledge, maybe get into more detail or test themselves with practice questions for the MSRA, definitely check out passthemsra.com.
Lots of resources there.
And for even more free materials to help your revision, head over to freemsra.com.
Great plugs.
Well, thank you so much for walking us through all of that. And thank you, everyone, for joining us on this deep dive into rubella.